Before you watch this movie, we'd suggest that you first take a look at the one in this section that deals with the general principles of incisions. It outlines the fundamental concepts that you need to grasp before learning the details of wound construction. The main incision is the very first surgical step in phaco, and it's an important one, because all the subsequent steps depend upon its correct construction. Get this wrong, and there are many ways in which you can do so, and you'll spend the rest of the operation paying the penalty for it. When considering small incision surgery, the advantages of a clear corneal incision over a scleral tunnel include its speed of construction, operating in a bloodless field, greater maneuverability of the phaco probe within a relatively shorter tunnel, a steeper and more favourable angle of attack towards the nucleus, avoiding damage to the conjunctiva, and finally the use of the incision as a refractive tool for reducing corneal astigmatism. So if you opt for a clear corneal incision, how do you decide where to place it? Well, to begin with, we'd encourage you to choose whichever approach is the more comfortable for you. Whether it's superior or temporal doesn't matter to begin with. As you become more experienced, you can then base your choice on other criteria, such as difficulty with access, or maybe to reduce corneal astigmatism by accurate placement on the steep meridian. Having chosen the type and location of the incision, we now come to its construction. The accurate control of the keratome through the cornea requires a consistently firm eye together with good fixation to give controlled countertraction. You can render the eye consistently firm by backfilling the chamber with viscoelastic through a self-sealing side port. For fixation, you can use either a limbal fixation ring or alternatively grasp the limbus with toothed forceps directly opposite the incision. You can grip the roof of the paracentesis or the limbus beside the incision, and this usually works fine. But occasionally you'll get poorly controlled rotational movement of the eye, particularly if the keratome is less than perfectly sharp. The incision itself can be one of three profiles: a uniplanar or stab incision, a biplanar or groove and stab two-step incision, or a triplanar incision with a groove, a tunnel, and an angled entry into the anterior chamber. Although of the three the uniplanar incision is the simplest and the quickest to construct, it's not particularly the recommended choice for a novice phacosurgeon for the following three reasons. Firstly, the stab incision is a little less consistently self-sealing. Secondly, if you have to enlarge it, it can be difficult to still maintain the precise architecture that you need for wound stability. And finally, the posterior edge of the roof is sometimes very thin and feathered, and consequently vulnerable both to tearing and the effects of wound burn. The biplanar incision involves cutting an initial groove, which is the width of the intended wound and is perpendicular to the cornea. This tends to provide a more reliably self-sealing wound and a less vulnerable posterior edge. It can be cut very accurately and consistently by first marking the intended width using calipers, and then cutting the groove with either a guarded diamond blade, which has been set to around 300 microns, or one of the preset disposable blades of the same depth like this one. These are more affordable but non-adjustable and non-reusable. However, with experience and judgment, you can achieve a perfectly acceptable result just with freehand use of the keratome or other suitable blade. Aim for about a third of the thickness of the cornea. Just be aware that if you do go too deep, to 500 microns or more, you will induce some astigmatism. However, this can of course be used to your refractive advantage where appropriate. To make the tunnel, firstly engage the tip of the keratome in the base of the groove. Then, with the blade pressed flat down and pointing slightly upwards, make a steady and controlled pass of the keratome through the corneal stroma and into the chamber up to the full width of the blade. You should be aiming for a tunnel length of about 2 mm to give a self-sealing and stable wound. There are keratomes available like this one that have registration marks on the face of the blade. They're designed to help you judge the right tunnel length. This can be helpful in showing you what a 2 mm tunnel looks like, so you can then reproduce it with any blade. If you're producing a tunnel that's consistently too short, then angle the blade more upwards to make it longer, and vice versa if you're producing tunnels that are too long. A steep entry incision looks like this with a profile that's arrow-shaped, whilst a shallow angled entry gives a curved or smile-shaped edge. The architecture of the triplanar or three-step clear corneal incision was originally designed in an attempt to guarantee a self-sealing and completely secure wound. Practically speaking, it's difficult to be convinced that it's any more stable or watertight than a simpler two-step incision. The distinction is probably not one of any great practical significance. The third step simply involves making an angled rather than straight entry into the chamber. You do this by tilting the blade heel up and toe down. As you do so, you'll usually see the characteristic corneal dimple appear from the localized pressure of the tip. What this angled entry achieves is the third incision plane that goes through the floor of the tunnel to connect it to the chamber. It's often performed in any case during an intended two-step incision if you need to enter the chamber more acutely because the tunnel's already long enough. There is one particular triplanar incision that's worthy of mention on its own, and that's the hinged incision described by Langermann in 1994. He designed a three-step clear corneal incision with a deep pre-groove of 750 microns. The tunnel was made about halfway down this groove. The aim of this was to create a hinge effect that would encourage closure of the tunnel floor against the roof. This produces a wound that's watertight even to pressure applied to the back edge of the incision. However, it was soon realized that a deep pre-groove like this had a significant astigmatic effect, similar to an arcuate keratotomy. You do need to take account of this effect if you choose to use this type of hinge incision. So, we've outlined the main factors to consider when choosing your type of incision, and then demonstrated how to construct the different architectures of clear corneal incisions. The one-step, the two-step, and the three-step. Remember that a correctly positioned and accurately constructed incision is an essential precursor for the success of the surgery that follows.